All right, fabulous. I am under the belief that Representative Rhodes is in Florida still with her mother, so she will not be in attendance today. So I'll open the subcommittee meeting on House Bill 1079. And just to remind the folks what this basically is it's looking to adjust the amount of part-time hours that a retired member can work in the system, or that's in the Group 2 system, and make adjustments forward with that. To give you an idea of what 1,664 hours looks like, that equates to 32 hours a week. The current statute of 1352 equates to 26 hours a week. And of course, to cover what RSA 100A7B means, that is working under a declared emergency. So that's already in statute, but that, in the event of a catastrophe, exempts those hours from even becoming a factor here. So with that, I'll be happy to open the discussion on thoughts in reference to this proposed change.
Mr. Chair,
Yes.
my feeling is that we changed this relatively recently, and we haven't really heard major problems from it. As long as the allowance is there for cases of emergency, I don't feel that it needs to be changed back at this time.
Okay. The other thing too that I'll point out, because we, being cognizant of what's going on in the Seacoast, and Hampton Beach certainly becomes the largest town in the state, in the summer, especially on a weekend, looking at that total number of hours, hiring someone for the limited summer that we have in New Hampshire here equates to 640 hours. So we're not even in the ballpark of concern in reference to if Hampton was, or Rye or Seabrook was in need of hiring part-time police officers to handle beach season. We're not even remotely close to having an issue with those hours at 640. So that, I just wanted to throw that out there as as we're kind of putting a reality to what these hours look like.
Thank you, Mr. Chair. And I, too, would agree that what we have in place now is sufficient. You look around at other states, and there are other states out there that don't allow retired workers to even come back and work. We've met a balance as to, with the separation from employment, 28 days, we allowed for police officers to maintain their training and their certification in those 28 days so that they can come back still certified. We've talked about this numerous times, and if anything, the number of hours could actually even be reduced. As far as I'm concerned, it's when you're retired, you retire, not to retire to come back to work in the same position you were. And in these cases, they can come back, they could retire, and someone could retire if we got rid of the language in this bill. If we past this bill right now that's here before us, you have individuals that could retire in April and still work full-time in the Seacoast communities for the summer months, collecting a full pension and working full-time. And I have an issue with that.
It's also been brought to our attention in the reference to those that are in the teachers in Group 1, that this would exceed their actual full-time hours. So in essence, you could have a teacher retire and just continue to work full-time under this, almost under the current numbers. Absolutely, when we go beyond that to over 1,600.
And that's my concern and why I say, you know, if anything, I would be for reducing the hours.
So the other concern that I have, again, in discussion here, is twofold. One of that involves the income stream to the pension system. We've made a lot of changes over the years that have been done under the guise of reducing benefits, but it's also shut off an income stream. And where the retirement system relies on investment returns to function, we have to be careful as to how many of these income streams we shut off. And that's my concern with what the quote unquote decertification problem, in the sense that an agency can eliminate a full-time position that pays into the system, and then not only is there an issue in reference to their debt as assigned to that position, but also it shuts the income stream off completely. And we have to be careful with that, because we do heavily rely, well, not heavily. Right now, it's about, what, 85-15, I think. 85% of the members' contributions covers the payouts, and we rely on about 15% of investment returns. But I don't want to see that number start to change, certainly. That's, and it would be great, frankly, if it was, if we didn't have to rely on investment returns at all, but that's just not reality. So, so there's that is a function in this. And the other thing too, before I get to you, Mark, is in 2010 there was a lot of looking at the concept of double dipping, and we had some examples in the state of New Hampshire where that was occurring, and this really doesn't, this goes in the other direction when it comes to the concept of double dipping. And that's something that both structurally and in the sense of public perception has been something that's not really gone so well. So, I think that we have to be careful here, bringing back something that literally goes against what we fought for in the cases of double dipping. Representative.
Thank you. This one is a tough one. I see problems on both sides of this issue all around. I understand the, on the one side, unless I'm confusing this with another bill, and I don't think I am, on the one side, you've got the issue of people retiring, but then working essentially full-time. Not ideal, and it makes for problems with personal relationships and the possibilities of corruption. On the other hand, if a person has worked X number of years, fully vested in their pension and is beginning to receive that pension, well, they've worked for it and they've already paid into it, so it's theirs. And what they do beyond that is really no business of anyone's, frankly. On the other side, I see the problem of streams of income for the pension system. But the flip side of that, to me, is, again, they've already paid in their pension. So what their working situation is beyond that, I mean, they're not sucking money out of the pension system that they haven't already paid into. Although I do understand, like you say, it represents a decrease in income for the pension system. On the other hand, not getting more money isn't the same as losing money. So I'm have a completely open mind on this, and I'd love to be convinced one way or the other. Not easy.
Sure. One of the things that is healthy, and this is some, I get some people that have a hard time with this concept, but it's better for the pension system for an employee to work longer, right? Because they're paying rather than collecting. And even though that gives them a larger pension as they move forward, overall for the system, it's better for employees to work longer. That's part of the reason why the change in 2010 changed the minimum amount of years from 20 to 25, because it was just overall it was healthier for the system. It wasn't necessarily healthier for the employee, but it was healthier for the system. So, this is one of those things where I think, we've done two things here. You know, let's also not forget that when this was enacted, there were approximately 2,000 employees that were grandfathered as well. And they're still all out there. Those folks can still function with absolutely no limit. You know, and that's, of course, attrition will get, you know, we'll remove them over time, but it's going to take a long time for those 2,000 grandfathered retirees to be, in essence, to die, I guess. I mean, that's really how that's the only way you attrition out of the pension system. So, yeah, I don't think that, you know, I haven't seen a compelling argument really as to why this increase is necessary, other than some communities just don't want to ante up the money to hire the full-time people that they need. So, I mean, I think we're kind of all on the same page with that.
And we also saw, Mr. Chair, that there were some cities and towns that were going away from full-time positions,
Right.
creating part-time positions. And when they do that, they walk away from the unfunded accrued liability portion by doing that. And what that does is spread that out amongst all the other communities in the state. So when you remove a position from a full-time paying into the system position and you make it create a part-time position, you've also walked away from that unfunded accrued liability payment on that position as well. So that's one of the other issues we had, and that just goes back onto other cities and towns picking up that rate.
You know, and I think until we really address how that's dealt with specifically, I think we need to be cautious here about further adjustments, because as of right now, statutorily, it's not well addressed as to how that's dealt with. And I think that that's something that there needs to be legislation in the fall. Not that I'm encouraging the creation of another commission or committee, but I think that there needs to be a look at what we need to do statutorily to say to a community, no, if you've got $5 million worth of pension debt, you can't walk away from it by simply just making all your people part-time. That's not fair to the other communities. So I think that really warrants a deep dive before we start making further adjustments here. Well, you know, I guess it would really come down to if Representative Allegro has any other questions or concerns in this matter.
There we go. I'm just having a problem sorting out which is the greater of two evils, but it seems that the rest of the committee, or subcommittee, I should say, is of one mind. And so it's not 3-1. I think it's 3-0-1. And I don't have any questions. I just need to think.
Yes.
If I may, the question is not whether the retiree should pay into the retirement system on the hours worked. Nobody believes that should happen. The question is, should the employer pay into the retirement system to cover the accrued liability of the position that is now not contributing? To be paying once he's retired. We want the town to consider its obligations. And a number of towns and school districts have told me that they specifically hired retirees so they wouldn't have to pay the pension contribution on those wages.
No doubt. It's just that, you know, basically in this particular piece of legislation, that's not being addressed at all. This is simply just asking, do we adjust the hours in a calendar year? Now, we could certainly, you know, there can certainly be some discussion as to whether this is amended to start talking about the specifics of that, but I don't know. I mean, we'd have to get a ruling if this is going on beyond the original intent as far as it being germane or not. And again, I don't, you know, the representative that filed this, Representative Trottier, Wasn't really in his address, did not really touch upon that at all. It was really just a matter of an hours adjustment.
I would say that if you choose to adjust the hours either up or down, that's fully germane.
Oh, sure.
If you try to add additional payments by anybody, that is seriously not.
And I agree, that would be a complete tangent off of what the intent of this bill is. So, again, looking at 1079 as it exists, it's basically a matter of does this committee agree that the number of hours should go up? And it's pretty clear that they do not. So, I think we should leave this as it is. It's only been changed. It's not even 5 years old that these hours have been changed. So I think that, I think a little bit more time needs to happen here to look and see, what that translates to. And also too, keep in mind, and I want to be clear here, this is not a limit on the number of hours an agency can do. This is a limit on hours of a specific retired employee. So this is not handcuffing a department from hiring 2 or 3 part-time people. It's just, there's no prohibition there. It's just a matter of per employee. So I want to make sure that that's understood. We're not harming, a police department that has a need here. They're just going to have to do it with more than 1 or 2 people. That's all.
Nobody's got anything on? No.
Test? Yeah, okay. So unless they're limited by the number of potential employees available, under those circumstances, they could be limited. But if there's an abundance of employees that want to come back part-time, they're okay.
Yes, Representative Goley.
And just one last thing, as we talk about the hours, we saw in the executive orders from the governor, he exempted them from the number of hours they could work during the COVID relief in one of his executive orders. So it does work in a time of emergency when these officers or firefighters or anybody are needed in that time. So it can be done.
All right, very good.
That was a concern of mine also, the fact of taking out that language for the 28 days, and the fact that we do understand that there are emergency situations that need to be covered, and I think this bill doesn't really help either of those situations, so.
And I'll just remind the committee one more time, RSA 100A7B is the one that allows working under a declared emergency. The limits just that don't apply. So that's already in statute. That is irrespective to what happens with this. So cool. I think so. If there's anything more, I think the committee has made it pretty clear that they're not in favor of this. So, all right, I'll close the subcommittee hearing on 1079 and hand the room over to Representative Lekis, who's got a 9:30 subcommittee.
Mr. Chair, do you need a motion?
If you'd like a formal motion, we can formal motion ITL, sure.
Is that you making the motion? Or
No, I believe that's me putting words in your mouth. All right. All right. And I'm certainly in favor of that as well.
So my understanding is that this is not an official vote, right? So I
No,
can...
it's a subcommittee recommendation.
Yeah, I can abstain right now and think it over. Thank you.
Okay. All right, then we are adjourned.
All right, we've got a few minutes, so I'll wait until the official starting time to be official.
That may be necessary too for the
they now? Okay.
That's why everybody's gotta be in their seat instead of us
Huddling,
huddling.
yeah, okay.
They don't want that anymore.
All right. Let's see who shows up. Actually, oh, Valentine's Day.
You can't have that, that's Steve.
Mine's over there.
Actually, that would be
Carol's, thank you. I think we have to sit at our seats, Steve was saying, because they are recording these and, I mean, don't be sorry, I'd prefer it that way, but that's what Steve said anyway. Yeah, for Valentine's Day, we don't go out because the restaurants are crazy. I'll pick up something interesting on the way home. Yeah. Well, we've got about a minute. So I guess Representative Rhodes is still in Florida helping her mom with her mom had a fall. Right, I was wondering that as well. But I guess her mom broke her hip. Yeah, that's bad. And Representative Marsh. So far, unless somebody shows up at the last minute. And it is 9:30, so I'm going to open the subcommittee work session on House Bill 1192. So the Senate has a bill, Senate Bill 282, which they've amended and passed on the consent calendar, which does, I think, everything we want. I mean, I've got a few copies of it in case somebody wants to see it as amended by the Senate, but it's going to come to us anyway. So my suggestion is to recommend that we just hold on to 1192 until we get Senate Bill 282, and then we can decide what to do, which will probably be, I would say probably to review and go along probably with 282 and then ITL 1192, but we can wait on that.
The issue is we're not going to, the issue is we won't get Senate Bill 282 until after crossover. And we have to do something with this House Bill 1192 prior to crossover.
I don't know, actually, did Carol go out, walk out? Anyway, bills will be coming over time. They don't all happen at crossover, and since they've already acted on the bill, we're probably going to see it before crossover.
Maybe.
Maybe.
In any event, my recommendation is we either send 1192 to interim study, or we adopt my amendment 0368H, which would make 1192 identical to Senate Bill 282, and then the question becomes moot.
Right. I talked to Chair McGuire, and she, wasn't happy with the idea of having two identical bills, one House, one Senate. If you look at in January, we had a whole pile of, on consent of ITL bills that were there because the other body had done already done it or other similar reasons. But we don't have to decide that right now. If we recommend holding on to it, we can decide that later. Any other thoughts?
I agree with what you're saying. I think we should just hang on to it, and when we get House Bill 282, if it is what we want, we use that. But I don't think we need to. We can ask the clerk where Senate Bill 282 stands, but I don't think that. I think we'll get it before crossover.
Yeah, as I recall from last year, the bills were, Senate bills were coming in well before crossover, so. But again, I mean, if we come down to the deadline where we have to act on it, we can do something with it, but, okay?
I'm okay with that, so we just recommend doing nothing for right now.
Okay, if we have a consensus on that, then I close the subcommittee work session on House Bill 1192.
Okay.
which is always a good sign.
Sure, no doubt.
It was unanimous out of the committee and passed on consent.
So I guess they won't object if we take it. All right.
All the the acupuncturists were here, met
Yep.
with them, and I actually called them up, and Peter did, and they said they're completely satisfied with what the Senate did.
Oh, well, that's cool then.
So
That's even easier if they're happy.
they're happy, I'm happy, we can all be happy.
Sure.
Good morning.
Hi, hi.
for Representative Schmidt. We're not gonna exact anything today, so this is no labor. And we can't actually, this. Well, I'm sharing, so good 2 hours, easy. There's no exec notice, so we can't do anything. Oh. Good morning, everyone. Good morning, those of you in the world of YouTube. This is the Executive Departments and Administration's public hearing on a non-germane amendment. This would be Amendment 2022-0399H, attached to House Bill 1330. And I will call this meeting to order. Representative Yakubovich, this is your non-germane amendment, so you have the floor, sir.
Thank you, Mr. Chair. We had a subcommittee that worked through the bill, and that's where I introduced the amendment, and it needs to go to the full committee and have a hearing. The amendment, so what we discovered in subcommittee and other related conversations.
Yes, Representative Vigoli?
If this is a public hearing on a non-germane amendment, I'm just curious as to if he should be over here with a pink card filled in, or how does this work, is my question, if it's a non-germane.
Yeah, I mean, but it's an amendment. I mean, if you want, we can have him in the hot seat. That's fine. Sure. Sure. Either way.
It's the right way.
Sure. Thank you, sir.
You've got those two.
Okay. The microphone's very necessary. So if that's not going to work, you may have to go back to your seat. We are. So see if we can figure out, get somebody down here. Thanks. We may also have to, if we can't drag a microphone over there, we may have to wiggle things around a little bit with a table.
Now it works.
Okay. Is that one working? Yes. Representative Grote, does yours work?
Yeah.
All right. Oh, there we go. I have power and a microphone.
Test 1, 2.
Fantastic. Thank you for coming down. All right, Representative Yakubovich, let's try this again.
Thank you. All right. Glad to be back. Thank you. Michael Yakubovich of Hooksett, Merrimack 24, introducing the amendment that was the result of our subcommittee. So the amendment deals with medical technicians, the registrations of medical technicians of New Hampshire. And we discovered after conversations subcommittee, some conversations elsewhere, that New Hampshire is the only state that licenses medical technicians. Then we discovered also that medical technicians are supervised by doctors. They don't really have a place to work outside of labs and hospitals. General consensus among the subcommittee and some outside conversations with parties involved, and our representative doctor, I believe, also spoke in favor of just repealing the board and simplifying our statute. That's where I'm at. So this is the amendment. That's what it does. Thank you.
Representative, could you elaborate as to why on lines 12 and 13 you've struck out an RSA? Is 328I, is that the section that covers medical technicians?
Precisely,
It is.
yes. Since it's been repealed, elsewhere, references elsewhere throughout the statute needs to be cleaned up. So that's what all
I think
those
if you look
things
at
do.
line 20.
Got it. Yep, no, makes
328I.
sense.
328I is the chapter.
All right, wonderful. Thank you. Does any member of the committee have any questions for Representative Yakubovich? Representative Goley.
Thank you, Mr. Chair. Thank you for taking my question. We've heard a number of times in testimony that we were the only state that does this, and I'm hearing conflicting information. I've heard there may be 11 states out there that either register or license this group. Do you know if New Hampshire is truly the only state doing this, or are there other states out there?
In my belief, New Hampshire is the only state, but please, if you have any other data, I'd love to see it. Thank you.
Anyone else from the committee? Seeing none, thank you, Representative, for introducing the amendment.
Thank you.
Mr. Chair,
Yes, Representative Goley.
could we have our researcher look into that information, seeing this isn't a timely bill and we have a little bit of time to get that information for us?
Absolutely. The chair calls Senator Sherman. Did I see Senator Sherman?
He's not here yet. He asked me to put it in the card
Okay.
because he's under time constraints.
Then we will switch over to Miss Bizzaro. Is that, am I pronouncing that correctly, from the New Hampshire Hospital Association?
Good morning, members of the committee. For the record, my name is Kathy Bizzaro-Thunberg, Executive Vice President, New Hampshire Hospital Association. I'm here this morning to testify in opposition to the amended version of House Bill 1330. And I just wanted to share a few comments. One is that the New Hampshire Hospital Association, representing our member hospitals, are supportive of the original bill as introduced, House Bill 1330, which would change the board to an advisory capacity. The reason why we believe that the MedTech registry is important is because several years ago, and I think this is something that Senator Sherman will address, is that we had a very serious situation in our state with a cath lab technician that stole opioids for his own use and impacted the access to care for patients, as well as infecting many patients with hepatitis B. Those are very serious patient safety issues, which is one of the reasons why this MedTech board was created to begin with. There are several types of positions that are covered under the MedTech registry. And again, I just want to also clarify, this is a registry, this is not a license, so this is just a list of professions that are registered with OPLC as being in practice in New Hampshire that have access to opioids and patient care. So the list for the record of those that are part of the registry are anesthesia technicians, cytotechnologist, diet technician or nutritionist assistant, emergency room technician, endoscopy technician, histology technician, histology technologist, lab assistant or lab specimen processor, medical assistant, medical laboratory technician, medical technologist, paramedic, phlebotomist, polysonographer or sleep lab technician, registered respiratory therapist, senior medical technologist, and surgical technician. I also wanted to address a question that Representative Goley asked about other states that may license these types of positions. I believe the 11 states do laboratory technicians as licensed. Lab techs do fall under New Hampshire's registry. So we don't license them in New Hampshire, we register them. So there are other, of these other positions that I mentioned, there could be other types of registries, certifications, or licensures at other states. New Hampshire took the position of registering these types of positions. So with that, I'd be happy to answer any questions of the committee.
Thank you very much, Representative Allegro.
The technician that kicked all of this off by the theft of controlled substances, were they, excuse me, I want to shift over so I can actually see you as I'm speaking to you.
Thank you.
Were they not prosecuted for that theft?
They were.
Follow up, please. So then there is a powerful legal mechanism to deal with people who do things like that then.
I think the point of being a registered position is that there is an opportunity for when you hire someone, if they have already been registered, if there was any discipline against them, at least in the state of New Hampshire. I think under the original intent by Senator Sherman, and I would hope that he could be here and speak to this, he would love to see a national registry of these types of positions, but felt like because there was nothing in New Hampshire, we needed to start somewhere. So at least it's an opportunity for a place for people to file complaints and understand if someone is in bad standing.
Thank you.
Representative Schuett.
Thank you, Mr. Chair. Do you recall how many deaths that medical technician that was prosecuted caused?
I don't recall that number off the top of my head.
There were some people, some of the patients that did decease, though, is that correct?
Correct, in New Hampshire and in other states where this particular person had practiced.
Thank you.
Representative Marsh.
Thank you, Mr. Chairman, and thank you, Kathy, for taking my question. It seems like one of the key questions here is whether other states, in fact, require registration or certification or licensure or whatever of these kinds of people. And I'm looking right now at the website of the American Society of Surgical Technicians, and while it looks like New Hampshire is the only state that specifically requires registration only of these technicians who are in contact with who have access to opioids, it looks like they have a list of 12 states, and I'd be glad to read them, that require education and certification of surgical technologists, and an additional 3 states require surgical technologists to register in order to work. Does that match your understanding?
Yes.
Thank you very much.
Representative Fellows.
It seems to me a little strange, like this registration is called technicians, medical technicians, but when you told us the list of people that were in there, a lot of them sounded like positions other than what you might call technicians. So one of the things I noticed just by Googling, not that I know anything about hospitals or medicine or anything like that, is that some states have a registry or a licensing process for people who have access to controlled drugs. And I'm wondering if we're calling it medical technician, but really is it more trying to trying to identify people who have access to controlled drugs?
Yes, that is the intention of New Hampshire's registry, is specifically for healthcare professions that aren't otherwise licensed, for instance, RNs. They're not in this list, but they have access to controlled drugs, but they're already licensed by the Board of Nursing. So the list of positions that I read off for you are those that aren't otherwise licensed or certified by some other New Hampshire board.
Anyone else on the committee have a question? Representative Goley.
Thank you. So we hear that licensing and registering individuals and having boards is for the best interests and safety of the public. And hearing that deaths were related to some of the things that went on in the previous individual, would not registering these individuals be in the best interest of public safety and health?
Yes.
Thank you.
Representative Lekis.
Thank you. I'm just wondering if you happen to know if the person you mentioned who basically committed a number of crimes, if registration had been required, would he have been eligible for registration? Because it appears, and let me know if I'm wrong, that the main thing would be if there was a prior record of disciplinary action, so.
If the MedTech registry had been in existence when this individual was hired into New Hampshire, he would have been required to register in New Hampshire.
Follow up?
Follow up.
I understand. The question was there anything in his history when he started to work that you know of that would have prevented him from being registered? What I'm getting to is, would the existence of this registry, if it existed before he was hired, have prevented him from being hired and then going on to do what he did?
I don't know the specifics of the hiring details, but I see that Senator Sherman is here and he had been intimately involved in that situation. He may be able to answer that question for you.
Thank you.
Representative O'Brien.
Thank you, Mr. Chairman. Thank you for taking my question. I imagine there's a host of federal regulations when you're dealing with controlled substances within the medical community. And other than the federal regulations and everything, does this particular bill enhance that and provide some proper safeguards? Can you just go over that? Does it add more than what is currently under the federal regulation?
The bill before you, which is an amendment to House Bill 1330, repeals the board, so it certainly takes away patient safety considerations. With the original House Bill 1330, changing it from a board to an advisory capacity still allows for these members of the profession to be registered and have oversight by OPLC.
Thank you.
Anyone else? Thank you for your testimony. The chair calls Senator Sherman, my historical mistake.
Always a representative, right? Thank you, Mr. Chair and members of the committee. I would like to speak strongly against the repeal of the Board of Registration, although as long as an advisory board would have the same ability to register technicians, I'm fine with the underlying bill. So in 2010, I was asked to form a new gastroenterology group in New Hampshire in Exeter. Their group had pulled out with only about 4 to 6 months notice, and I was commuting to Massachusetts, so they asked me if I would come and start this. I'd run a 10-physician practice in Virginia before, and so it was really exciting. And about a month after I started, we hired Hillary Tompkins, who's one of the best gastroenterologists I've ever worked with, and she's phenomenal. She was coming straight out of training. And we were a fledgling group. In 2011, we started having cases of acute hepatitis C. And in all my career, I'd never seen acute hepatitis C. It's a chronic illness. Typically, people who have had exposure to transfusions, needle sticks, or people like hemophiliacs, or people who had substance use disorder and were sharing needles. The treatment was incredibly difficult at that point. Some of you may know that we were using interferon and ribavirin, which can just have terrible side effects. But there were great new drugs in the pipeline. Mass General had a study on these. Hillary and I were sitting there literally at about 5:30 after we'd finished seeing all our patients, and we're puzzling over 2 charts. They were both patients in their 80s. Not your classic hepatitis C patient. And neither of them had any risk factors for hepatitis C. So we started going through the charts together saying, this is weird. The other thing to know about hepatitis C is that you don't usually show symptoms. So hepatitis B, you typically will get jaundice, yellow skin, yellow eyes, yellow urine, or dark-colored urine. but not hepatitis C. It's only a small fraction of people who will actually manifest symptoms of hepatitis C. So these two elderly gentlemen had acute hepatitis C by their blood work, but they were also symptomatic, and that's what flagged us that there was something going on in them, and that's why we did this check. Turned out the only thing that connected these two gentlemen was the cardiac catheterization lab at Exeter Hospital. And you know, the aha moment was a horrific aha moment, because the implications were that if this was correct, or if this were correct, then everybody going through the cath lab was at risk. So we called the hospital, they notified the state, and many of you who were here in the state back in 2011, 2012, that's where the hepatitis C outbreak first got its start. Shortly after that, working with the Hospital Association and others, we started the statewide steering committee, which was an incredible group. Every single stakeholder in the state who was we were devoted to trying to make sure that no one else was impacted by drug diversion. The impact was enormous. And this gets to Representative Lekas's, did I say your last name? Is it Lekas? Sorry. Representative Lekas's question. In the state of Michigan alone, the guy who was eventually found guilty of this, Kwiatkowski, had gone to 5 different hospitals in the state. They had no way to track him. He was a radiology tech. So what he would do is he would take the cardiologist, or if they had an anesthesiologist, was laying out the fentanyl for the next case. They had it out on the sterile field. And then, so what Kwiatkowski would do was he would take the fentanyl, inject himself with it, draw up another syringe. Now, remember, when he injected himself, that needle is now dirty. He'd draw up another syringe, the same syringe, put it back down on the table. So the patient, number one, didn't get any fentanyl. And number two, got some of Kwiatkowski's blood every time. It would be like it was somebody suffering from substance use disorder sharing needles. That's exactly the model. And we know that in addiction, when shared needles occur, within the first month, if you're sharing needles, you have about an 85% chance of getting hepatitis C. So that's how contagious it is once you have even droplet level transmission. The U.S. attorney, whose name it was John Kakavas, was brought in because this was clearly a criminal case of drug diversion. We ended up with 32 people in just the Exeter community infected. One of them was the very close relative of one of our Republican state senators and who eventually died. So he became a very strong ally of ours. Some of you may have known Senator Cataldo. And then Jose Montero, who was the state chief medical officer for the Department of Health and Human Services, they did their own investigation. And there were, I think it was 2 or 3 state reps from Exeter and Stratham, one of whom is Tim Copeland, who actually I spoke to on Friday. Tim is a retired New York City detective, and to him this was criminal, and we needed to make sure that in the state of New Hampshire we did everything, and I think you were with me on this, we needed to do everything we possibly could to make sure this never happened again. So we got Tim to participate, because he was a state rep, on the statewide steering committee, and we started thinking about legislation. And essentially, we did 4 pieces of legislation out of this, because what we learned was that Kwiatkowski fell into this gap of people who had access to patients and access to controlled substances, but was not listed anywhere in our state's regulatory system. So, you know, physicians, I'm overseen by the Board of Medicine, PAs, Board of Medicine, RNs, the nursing board. We've since formed the Board of Radiology Technicians. And Senator Carson and I did that together. So, but all of these are regulated except this one group of, in a broad term, of technicians or assistants who have access to to controlled substances like Kwiatkowski did, and also have access to patients like Kwiatkowski did. The difficult part was trying to figure out how to define this group. It's a really diverse group of professionals. Some are radiology techs, some I work with endoscopy techs. We have techs in offices, and so you don't want to get every single medical assistant, you don't want to get every single endoscopy tech, you don't want to, if they don't fit into this gap, the very specific definition of those with substance use and, with the controlled substances and access to patients. So it was a re-referred bill, it was in the House. So we worked on this for a year and a half, or at least a year, and brought it back with pretty much unanimity to close that gap. And that's what the board does. These are not people who are certified, they're not licensed, so we're not looking at competency. We just want to know who they are, and to follow what we saw happen in Michigan with this one fella. If there had been a board of registration, he would not have been able to jump from hospital to hospital. And if you know the story, he actually ended up going to 16 hospitals before we caught him in New Hampshire. And the only reason we caught him was because our little fledgling group got every patient from the Exeter catchment area into one gastrointestinal group or liver group. Otherwise, if I used to practice in Lowell, if it had been Lowell, we have 8 physicians or actually now 10 and 2 separate groups, this might never have been discovered. But because it all comes into one funnel, we got all of the patients that he would have impacted. Nationally, Kakavas said that he would have impacted, the people he put at risk were over 8,500 people. 8,500 people. And there were deaths not only in our 32 patients, but also nationwide as a result. Because of course they went back and looked at, oh my gosh, what about hepatitis C? He was at Johns Hopkins. He was down in Texas, 5 hospitals in Michigan. When they traced it back, all of a sudden there were deaths that were being attributed to this guy's behavior. Now you may say, wow, all of this in response to one outbreak. It's not one outbreak. Drug diversion, this was my 5th case that I knew of that had touched my practice of drug diversion. And I would point you to one just before us that was out in Denver at Rose Memorial, which is an HCA hospital. And they had multiple deaths, huge hepatitis C outbreak. And that was the exact same. It was actually an anesthesia tech, which would have fallen actually even more so into our board of registration. So the definition of medical technician is one that we came up with to capture this group. And then we further refined it by saying only medical technicians with exposure to patients and access to controlled substances. So the idea was to regulate as few as possible, more like a scalpel than a sledgehammer, as few as possible, but to make sure we capture so we don't have any gaps in all of the people that we're keeping an eye on in the state, to make sure there's no behavior that would make it so we don't want them practicing in the state of New Hampshire. There were several national articles about this afterwards, and we talked about the board. I was interviewed for one of them. We talked about the board of registration for medical technicians in that. Our hope was that New Hampshire was the first, but that it wouldn't be the only. As long as it's the only, it only protects us from people who are moving from hospital to hospital within our state, right? It doesn't really protect us from somebody coming in from out of state, except that once they're here, if their pattern is they start going, once Kwiatkowski was found down on the ground with syringes in his coat pocket, syringes of fentanyl, and he was just fired. This was at one of the other hospitals of those 16. Nothing was reported, police weren't called, he was just moved on. That would not happen in New Hampshire as long as we keep this registry intact, because there's no place for that person to move on to in New Hampshire. We also put in place a drug-free workplace requirement for all licensed healthcare facilities. That was another bill. These were all strongly bipartisan. And the really telling news is that we've not had another significant outbreak or drug diversion case in the state of New Hampshire since then. So that's the historical background for where this came from. As I said, I'm absolutely fine with it being something that doesn't require a quorum, but still has the oversight and registration, and that stays as narrow as this one is. I don't want to regulate everybody. I just want to regulate those who have a real chance of putting patients at risk. So I'll stop and take any questions anybody has.
Representative Lekis?
Thank you. Actually, I'm shocked that the hospital would find something like that and then do nothing but fire him.
We were too.
Yeah. So my question is, given that, would this person, even given his behavior in another state, let's say they had a similar registration procedure, why would it be, if the hospitals aren't going to report anything or do anything, why would the registration board even become aware of that behavior? It's a horrible thing that happened, a serious problem, but it's not clear to me that this would actually have prevented it.
That's a great question, and it is up to responsible hospitals or employers. Remember, this could be an outpatient surgery center or something like that, or an urgent care area that has. One of the reasons that was cited for them not reporting was they had no real mechanism to do so. That it's either we call the police or we do nothing, and honestly, it's criminal behavior, and they should be calling the police. But we know that that's not always the case. But if you're terminated, like he was in that case, that has to go into the registry, the reason for it. And it's, for the hospital, it's not a high liability. They're required to do that. So it gives the hospital a much, even if it's just suspicion, they could potentially let somebody go. But it gives the hospital an in-between to report. And it is a requirement. It's a requirement for licensure. So were they not to do that, were it not to be reported, that would be a problem. The other problem is that this is also self-reporting. You have to tell why you were terminated, and that can generate an investigation. My medical practice partner was actually on the board when it started and helped to form it. And he was really amazed at how, two things. One is, when you have a board, it gives due process to discipline, but also he saw people applying to come to the state of New Hampshire with, you get the initial application, it would have some discipline issues in the background. And when they realized that they were going to be subject to review, they withdrew their application. So it is a deterrent as well as an active monitoring system. And if we take this away, we're back to where we started. The recommendation to do this was not only the recommendation of the steering committee, but also of the Department of Health and Human Services, and also the U.S. Attorney's Office. everybody recognized this gap. So I would ask you, with all due respect, not to reopen the gap.
Follow up? You mentioned that the employer would be required to report at least the reason for termination, maybe other things. I'm not seeing that in the bill. Is it elsewhere in
Right.
statute?
It is, actually, the way it works, because this was one of the 4 bills that we got in place, is that, if you terminate an employee for cause, and they go to another place, and that person asks you, say Concord Hospital and Exeter Hospital, there's somebody who has a discipline problem, you terminate that employee, they go over to Concord Hospital. Concord Hospital calls Exeter Hospital and says, what happened? Why did you terminate this person? Exeter Hospital, in the old days might have said, all they would give was, yes, the effective date of termination was X. One of the bills that came in gave indemnity to Exeter Hospital to report exactly why the person was terminated. And that was part of these, to make sure that communication, when patients' lives are at risk, that level of communication is open, and that the hospital, if they report honestly, truthfully, then they would not be subject to litigation. So that was another one, because the hospitals weren't disclosing problems.
Just one more follow-up, if I could.
Sure.
You understand, a number of businesses, the liability issue around providing that information. So is it just that they're not liable in that case, or is there actually something that requires them to report it to, let's just say, the Board of Registration or anyone else?
I can pull the statute. I don't remember the wording, but my recollection is that they have to report that, but that they are protected in that reporting.
Okay, thank you.
Representative Marsh.
Yes, thank you, Mr. Chairman. Thank you, Senator, for coming before us and help explaining what was a really confusing thing for those of us who are new to this. My understanding, looking at the registration process in the original bill, which is page 1, lines 22 through 27, is really 2 things are going to be red flags for the people that are problems. First is the pending criminal charges that may not be evident unless they're required to report it. And second of all is the work history, which means people who go from place to place to place to place are generally the ones who are a problem. Is that your understanding as well?
Yes, and just as you know, Representative Dr. Marsh, all of the other professions in healthcare have a national reporting between states. It's not federally overseen because that's not something that, it's like insurance. It's left up to the states to create their own boards and their own regulatory system. But they're all speaking to each other. So if I apply for to the medical board to become a physician in New Hampshire, they query not only the practitioner database, but also they will query any other place where I've had a license in the past. And that's a huge benefit to the people of New Hampshire, to make sure we're not having a bad apple from Maryland coming to New Hampshire to cause trouble here and then be a problem for the board. That was our hope when the Board of Registration, as I said, to stop people like Kwiatkowski from bouncing from state to state. He learned after Michigan, after going to 5 different hospitals, that he'd better get out of state and go to someplace fresh and new. And so he became a traveling tech. And that's how he ended up bouncing from hospital to hospital as a traveler. There are states that have done some form of this Board of Registration, but my comfort in this is that at least we have it in New Hampshire, and we've learned a very hard lesson.
Representative Bailey.
Hi, thank you for taking my question. this seems to be kind of after the fact. I'm sort of puzzled by, I think you said 8,500 times this person was left alone with the drugs? Isn't that really the place where you need to pay attention rather than,
Right.
oh yeah, 3 years ago he was in this other state, or?
So there's two ways that that's being paid attention to. Thank you for the question. It's a great question. After the Rose Memorial incident, what the anesthesiologists were doing at Rose was they were drawing up all the medications for the next case and then having them ready. You know, you're doing, and I hate to sound medical, but you're taking care of a patient. You've got a little bit of downtime while that patient's asleep. So you pull up the drugs for the next case, put those out on the table for the next case. You're ready to go, right? You're all prepared. That's when the tech, you would start turning over the room. The tech would be alone in the room. They could swipe those medications from the anesthesiologist. The same thing was the practice, standard practice across our state of preparing for a cardiac catheterization does not require an anesthesiologist. So the cardiologist, just like I as a gastroenterologist can have people using, I can direct the nurse to give fentanyl and Versed to my patients. That's also the case in a cardiac catheterization. So while there's no anesthesiologist necessarily involved, there is still the preparation of the medications. And if they are preparing them the case before, then that's the opportunity for the tech. That's pretty much moved out nationally for two reasons. One, in the state of New Hampshire, that steering committee, we identified that as a problem, and it's not standard of practice anymore in the state. But two, there's two major accrediting groups that go to every hospital in the country. They usually pick one or the others. One is called the Joint Commission. And when the Joint Commission comes through, they make sure that these practices are no longer ones that can put patients at risk. The 8,500 is the number of patients that he had access to in a setting where controlled substances were involved. That doesn't mean that he did this 8,500 times, but that's the number of patients that would have been at risk over the period of those 17 hospitals, including us.
Thank you.
Representative Judy.
Thank you, Mr. Chair. Good morning, Senator.
Good morning.
After 8,500, this guy still out there, or is in jail right now?
He's in prison.
He's in prison.
He's in Massachusetts. He got 30 years.
Only?
Only. And there's actually a documentary on it. So this made national news. I think it was Newsweek or Time, chronicled his journey through the healthcare system. And as I said, it was just luck that we were able to put the pieces together.
Yes. All right. Thank you, Senator.
Does anyone else have a question for Senator Sherman? Representative Sytek.
Senator Sherman, is there drug diversion among licensed professionals?
There is. In fact, I mentioned 5. One was a gastroenterologist in Leesburg, Virginia. I was practicing in Manassas, and when he went to jail, his patients came over to us, and they were amazed that they were actually asleep for their colonoscopies because he was stealing the drugs that were supposed to be used, and they were very uncomfortable.
My reaction is as follows. I'm blinded. I have trouble looking at this because none of this should have ever happened if there were proper background checks, if the trustees of the hospital weren't scared about this guy being found with the needles on him. And let's hush this up. I have no such knowledge, but I can just picture such a thing. And when my feelings settle down, I might be able to look at this a little bit. But I'm thinking, you've told me, this man, Kiskowski, criminal conviction, lots of hospital hopping, suppression along. We're looking at the tail, not of the dog. my story, I'll match your story. There was a teacher at my high school, known by all the teachers in the high school, who was doing things with a mentally challenged young woman. He left. He's teaching in Lawrence till he retired. Nobody, no, can't say a thing. So I'm having difficulties with this perhaps wrong cure for societal difficulty, and I can't really I can't sort that out.
Well, I share I mean, it's deeply troubling no matter how you look at it. I'd really recommend you go and read, if you want to get more troubled, read that piece in I can't remember whether it's Time or Newsweek, but you know, when you look at, for example, NASA, you look at really great hospital systems, you look at healthcare systems, the stakes, and hopefully school systems, the stakes are so high. People's lives are on the line. And in my world, trust is the fundamental that's on the line. You know, when I go to my doctor, I trust them to do the very best they can. And when there are techs in the room or nurses in the room, there's a huge amount of trust. You just can't avoid it. But there are a huge amount of redundancies built into the system. And for example, you come in for a colonoscopy. I'm sorry to keep inflicting colonoscopies on this committee, but it's my world. When you come in the old days, you've probably heard of wrong site surgery. Have you ever heard of that? There was a person who had the wrong kidney taken out, and the other kidney had cancer. So they lost both kidneys. I mean, that's unforgivable, right? So in colonoscopy, you come in and you're going to have a timeout. That means not you didn't do anything wrong, not like if you were a little kid, but it's a timeout where the whole staff makes absolutely sure not only who you are, but also that we're doing the right procedure. That's called a timeout. That has come not because it's a great idea, but it's come because with all the checks and balances we have, all the people doing the intake, people still get the wrong kidney taken out. So this is clearly not the only answer to making sure we don't have another outbreak or drug diversion, but it is a part of that redundancy in the system that has very low impact on somebody who's not doing anything wrong. But in terms of catching somebody or deterring somebody who is intent on criminal activity like drug diversion, this is one part of our repertoire, one arrow in our quiver to make sure it never happens. And I'll tell you, as someone who then had to treat those 32 patients afterwards, it was, I can't really describe what it was like in those times. There was one gentleman who we got through because all we had available in the early parts of this was this horrible combination of drugs, ribavirin and interferon. And I would see him every week during the course of his treatment. And when it was over, he cleared the virus and we celebrated together. But we were also responsible.
Senator Sherman, my mother was having a procedure done on one of her knees and took it upon herself with a Sharpie to write wrong knee on her other knee.
Smart.
When she had discussions with the doctor after the surgeon, he was not thrilled at that.
I would have been thrilled at that. I have patients who actually put a dotted line across the lower part of their back and said, if you can read this, you're too high up. You know, it's for a colonoscopy. But, you know, the more we do to protect ourselves and our loved ones, the better, as long as it's not overdoing it. And that's why I think this Closing the Gap, we worked really hard. And if we're wrong, if there need to be tweaks, that's great. But we worked really hard to get the definition that was imperfect, but really captured the smallest number of people in that huge group of professionals that make up medical technicians that would actually be regulated. So that, you know, there's a cost and there's work that's done on the registry side. And I think we hit the right balance, but, you know, I'm always open to suggestion. I just would ask you, please don't repeal it, because it is one, while it may be redundant, it may not be perfect, it is one of the things that we have in place to protect patients in New Hampshire.
Mr. Chair.
Representative Judy.
Yes, thank you. Senator, I'm back again. After infected so many people, how do you find out it was him?
Because I'm trying to think, this is public record. He was one of the patients that was in the group. So, you know, when you have a whole bunch of 80-year-olds who are infected or people with cardiac disease, and then you have one person who is infected with the exact same strain, you know, we can subtype hepatitis C, just like you've heard of Omicron and Delta and all that. We can do the same thing with hepatitis C. So we can, it has a fingerprint. So you follow the fingerprints and eventually he confessed.
Representative Schuett.
Thank you, Mr. Chair. Senator, you stated that you are okay with the underlying bill, which makes this board advisory, but would it be your preference to actually not do anything and leave the board just as it is in law now?
Not necessarily, because, you know, they're having trouble staffing the board. Really what I care about is that we register people in this definition. And that there's adequate oversight. If you just register people and you don't have any oversight, that doesn't help much. In fact, it's a waste of everyone's time. So if they're registered and they meet and they have essentially the same function, I don't think it has to be necessarily at the level of a board, but just so long as the function and the protection for patients is the same.
Thank you.
Anybody else on the committee have questions for the senator? Representative Fellows.
Thank you. Just on this last issue, I'm wondering if the board is just advisory and not, if they're advisory, that seems to imply that they can't make any decisions.
Right.
So if that gentleman were to have applied to be a tech in New Hampshire and the background check shows something suspicious, that if the board is only advisory, I'm concerned that he will just slip through and be registered.
I'll jump in on that one. Representative Fellows, the way the bill's written, this would fall under the Office of the Executive Director. So this would not be something that would slip through a crack.
That's exactly my concern, that it would be doctors and medical professionals that would feel comfortable to say, this person, we don't want this person. I mean, I'm not talking about, if he's been convicted, that's totally different.
Right.
But to see something suspicious or that needs follow-up, I'm concerned that somebody who doesn't have a medical background is not going to identify that there's an issue there.
Well, I would answer that with two things. One is I would defer to Director Courtney what level of oversight she would anticipate they are able to provide. Two is that she would have access, or I would have presumed this board would have access to all the different boards' expertise if they had a question about the clinical side. On the other hand, I think one of the drivers for this bill is that they just haven't been able to staff the board with healthcare professionals. And I don't know if Mike Padmore has spoken yet, but generally what we do is we hear from the boards that they need staff, like the Board of Medicine, the Board of Nursing. They'll go to the Nurses Association and then we get volunteers for them to serve on those boards. And I don't know if that was ever flagged for the Hospital Association or the Board of Medicine that they were having, I'm sorry, the Medical Society, that they were having problems staffing these boards. But if they weren't talking to the societies, that's probably why they weren't able to staff them.
Follow up.
We've heard from many, we've heard reports about many boards, not just the medical ones, that have a difficulty, holding a quorum and getting volunteers. Do you think if we were to add alternates to the board, then that would make it easier for them to be available? And also, we've talked about it, it's not in any bills, if they could participate via Zoom, that might work. It might not work for things when you're talking about a specific individual, but some strategies like that other than just making it advisory.
Well, anytime you ask any professionals to participate in something that's volunteer, that takes them away from their day job, it's difficult. And I think, we've seen that during COVID, we've seen that. But I think, number one, alternates would be very helpful. Number two is there is a benefit to being in person, just being able to see each other, like today, being able to look at you all in the eyes and make sure we're all on the same page and that I'm really answering Representative Lekis's question. But the reality is that virtual for some of these boards would probably make participation easier and facilitate people volunteering for it, because you'd get people from all over the state, which is the other benefit, is that you get a much more diverse group of participants.
Do we have any questions for the senator before I cut him loose? Seeing none, thank you, Senator Sherman,
Absolutely.
for your
Happy to come
testimony.
back if you have more questions.
That's going to be the last pink card I have concerning this public hearing on the non-germane amendment. I don't mind at all. But I'm gonna trust that since you wear an orange badge, you have a rough understanding of the procedures of how we operate here. So let's make sure we get the card going here.
Thank you, Mr. Chairman. For the record, my name is Mike Padmore, and I'm the Director of Advocacy with the New Hampshire Medical Society. I did want to just come and testify and just share our opposition to the non-germane amendment for HB 1330. I'm not going to repeat what Senator Sherman has outlined already. I think that he did a great job of explaining the background of why this board was established. What I would simply just say is, from our perspective, this is just a patient safety issue. As practices are hiring, building out their practices, they want as many different resources at their disposal as possible to make those decisions. This is certainly one of those resources. So I would just simply say, please don't take that away. And I think to one of the questions, and forgive me, Representative, the chair is just in the way of your name, so I'm just missing your name. But
this would be Representative
Sitek, sorry about that. I did just want to say, so you had brought up an analogy of an abusive teacher in schools. What I would simply just say is that's one of the reasons why I think we have a sex offender registry. It may not catch that first instance of abuse, but certainly the hope and the goal is to then prevent those abuses in the future. And I think the same concept does follow with this. Obviously, in the instance that Senator Sherman had outlined in the early 2010s, that first instance had gone on for many times. But the hope is, I think, is that if there is a registry in place, it does at least help prevent those abuses in the future. It may not prevent every abuse, but if it is one additional resource, I think the hope is that it can help to prevent those abuses moving forward. So I would just conclude my testimony by saying, please don't repeal this board. We do feel that it is a helpful resource to our physicians in the state, to our practices in the state, and I'm happy to answer any questions.
Yeah, I do have a question, and that's this. Suppose at a given hospital in New Hampshire, some personnel, technician, doctor, is caught stealing, and he's fired. When he goes to another hospital or another wherever, and they ask the original hospital, why did he leave? What would that hospital say? The original hospital.
Thank you for the question. I don't know specifically what they would say, but I do think in the case of physicians, they are regulated with the Board of Medicine, so there at least is that aspect of oversight that physicians do have from a professional standpoint. And as was stated by from earlier testimony, the reason why this board was established is because these professionals don't fall into any of those established boards. So this at least would provide some oversight to those individuals. To your question on the physician who's fired by one hospital, I can't speak to that specific instance, but at least there is that mechanism of the Board of Medicine that has oversight, and a complaint certainly could be filed by a hospital to the board, making the board aware that an offense had occurred.
Let me refine that a little bit. Suppose the doctor is let go because he maintains his credentials, but he's just not a good doctor. They don't like him. He's just careless, whatever, but he keeps his credentials. So he's out the door. What's the next hospital hear when they ask the original hospital?
So is the question, what is the recourse that that hospital has?
What kind of reference would he get?
I mean, I suppose it would come down to if that hiring hospital had reached out to the hospital prior, depending on what the physician's CV looks like. That is on the hospital that's hiring to go through the due diligence. I guess what I'm just saying in terms of this board is that this is one of those resources.
Does any other member of the committee have questions for the gentleman? Seeing none, thank you for your testimony, sir.
Thank you, Mr. Chairman.
Is anyone else in the room wishing to testify on this bill? Seeing none, I'll close the public hearing on the non-germane amendment 0399H. That is the final thing that we have, the only thing that we have as a board today, or as a committee today, is this hearing. So at this point, we're done for the day. Don't forget to sign in on a sign-in sheet before you go.
Watched the Super Bowl last night?
Oh, yes.
I didn't get anything on the squares.
I don't win nothing.
Either did I.
Yeah, I got it. Thank you.
Yes.
I thank you, sir.